Welcome to the Cardiac Critical Care Fellowship, an entirely online program designed to fit your busy schedule, offering 3 comprehensive modules, each worth 30 credits. Learn from world-class clinicians and gain access to evidence-based content, cutting-edge research, and real-world case discussions in cardiac critical care. This program is tailored for self-driven learners who want to take control of their education and unlock their potential. Whether you're managing critically ill cardiac patients or looking to master ECMO, mechanical circulatory support, or perioperative care, this fellowship will empower you to excel. With flexible, interactive, case-based learning, you'll gain the skills needed to advance in this high-stakes field, all while earning certification to boost your career. Join us today and start your journey towards becoming a leader in cardiac critical care. Are you ready to make a difference? Are you ready to advance your career in one of the most dynamic and impactful fields in healthcare? Welcome to the Cardiac Critical Care Fellowship, an entirely online program designed to fit your busy schedule, offering 3 comprehensive modules, each worth 30 credits. Learn from world-class clinicians and gain access to evidence-based content, cutting-edge research, and real-world case discussions in cardiac critical care. This program is tailored for self-driven learners who want to take control of their education and unlock their potential. Whether you're managing critically ill cardiac patients or looking to master ECMO, mechanical circulatory support, or perioperative care, this fellowship will empower you to excel. With flexible, interactive, case-based learning, you'll gain the skills needed to advance in this high-stakes field, all while earning certification to boost your career. Join us today and start your journey towards becoming a leader in cardiac critical care. Are you ready to make a difference?
Hello, everyone, and welcome to our program. Today, there will be 2 presentations, just a little bit of a housekeeping. My name is Salman Parvez Bhatt. I'm a ECMO specialist and working at 𝐂𝐧𝐭𝐢𝐜 as a perfusion manager currently. As a little bit of housekeeping from the start, we'll be having 2 guest speakers today. One will be presenting live, and the second one will be presenting through the video recorded session. And you will have time in between for 5 minutes for questions to be asked through the Q&A box. So feel free to ask any questions after each presentation. So I'm going to start with the first guest speaker. It is my pleasure to welcome Dr. Arvind Chandrasekharan, consultant intensivist and a director of ECMO program at K.K. Patel's Super Specialist Specialty Hospital, Gujarat. Dr. Arvind is a national board certified critical care super specialist from India. He is also certified by European Society of Intensive Care Medicine and holds adult ECMO certification from also. Today, he will be speaking on the title, ECMO and Anticoagulation, Striking the Perfect Hemostatic Balance. And Dr. Chandrasekharan is deeply committed to delivering a cost-effective, high-quality ECMO care to patients in resource-limited settings. So I would hand over to Dr. 𝐀𝐧𝐭𝐢𝐜 to start his presentation. Thank you.
Thank you so much, Dr. Salman, for your kind introduction. Let me share my slides. Oh, is it? Is everybody able to hear me and see my slides?
Yes.
Okay. Let me begin.
Dr. Arvind, I think you're on mute.
Am I audible right now?
Yes, you're good.
Okay. Yeah. So thank you for the kind introduction, Dr. Salman, and very good evening to all the attendees. So today we are going to discuss ECMO and anticoagulation, striking the perfect hemostatic balance, which is usually easier said than done. I have no conflicts of interest or financial disclosures. This talk is designed for those already familiar with ECMO management. We'll focus on the betterment of what we usually do every day. On ECMO, we actually walk a tightrope between thrombosis and bleeding. We'll explore various strategies to navigate this balance successfully, pondering on the latest evidence and clinical experience. Why this matters now? Three key important statistics underscore the urgency of optimizing anticoagulation. Number one, ECMO use has tripled or increased by 300% in the past decade, meaning more patients are exposed to these risks. Optimized protocols can reduce transfusion requirements by up to 67%, a massive impact on resource utilization and patient safety. And coagulopathy remains the leading cause of morbidity during ECMO support, affecting up to 40% of cases. So robust anticoagulation practice gave us an opportunity to curtail the major chunk of morbidity in ECMO care. Here's our roadmap for today. We'll begin with a case study of an ECMO patient with cannula site bleeding. Then we'll proceed on to dissect the pathophysiology of hemostasis disruption in ECMO, including the quintuple threat to coagulation. And then we'll review the various anticoagulants, monitoring strategies, and modifications in special populations like pediatrics and COVID-19. And finally, we'll end up with discussing protocol implementation and emerging technologies. Let's start off with a real-world scenario. A 35-year-old male severe ARDS patient is being planned for initiation of VV ECMO. Before initiating VV ECMO, our patient's coagulation profile was stable, INR and APTT within range, fibrinogen robust, platelets and hemoglobin adequate, and D-dimer unremarkable. But during the first 3 days of ECMO run, there is persistent oozing from the cannula site despite local measures. Heparin is being held intermittently, and multiple transfusions are being given. During the further 4 to 6 days, there seems to be deterioration in lab values and oxygenator performance. The ECMO flow was being maintained at 3 liters per minute, and finally by day 7, we have reached a critical point where the bleeding has worsened and an increased transmembrane pressure gradient is noted across the oxygenator. Hence, we go on to look at the oxygenator, and the oxygenator is telling a different story in a bleeding patient. We can see multiple clots here in the oxygenator, and the transmembrane pressure gradient, that is the P3 minus P2, or the post-membrane pressures minus the pre-membrane pressures, is highly elevated at 80 mm of mercury. We usually expect a normal transmembrane pressure of around 10 mm of mercury per liter of ECMO flow. As we are getting 3 liters of ECMO flow here, we expect a value of TMP around 30 to 40 mm of Hg in a low resistance oxygenator, but here the value is quite high. And the oxygenator performance seems to have dipped. And how do we know this? The delta PaO2, that is the post-oxygenator PaO2 minus the pre-oxygenator PaO2 value, is very less, around 50 millimeter of mercury. We usually expect a value of more than 300 millimeter of mercury with 100% membrane oxygenation. So what do all these suggest? It suggests that the clot burden in the oxygenator is increasing and there is thrombosis of the ECLS circuit. So now we are actually faced with a classical ECMO paradox, a clotting ECLS circuit in a bleeding patient. With regards to lab values, look at the stark differences between the pre-ECMO and the seventh-day ECMO lab values. We see that the INR and APTT climbing, signaling impaired coagulation. Fibrinogen is plummeting, probably consumed by the rampant clot formation in the oxygenator membrane. Hemoglobin and platelets are dropping as they are trapped in the fibrin meshes, especially in the oxygenator. And D-dimer is skyrocketing tenfold, and it might tell us about hyperfibrinolysis. Now, to an already complex situation, the TEG finding add another layer of complexity. The TEG tracing reveals an upstream hypercoagulable state. Hypercoagulable. You can see that there is a shortened R time and an elevated maximal amplitude, and which is mirrored by the clinical clotting of the ACLS membrane. But alongside, there seems to be another fire that is burning. That is an elevated LY30, which is telling us that there is hyperfibrinolysis. And this fibrinolysis doesn't seem primary, it is a secondary fibrinolysis to the primary upstream hypercoagulability, wherein the body's desperate attempt to dissolve those pathological clots in the ECLS membrane is actually taking a toll on the patient, causing bleeding. In such a complex scenario, what are the options that we are left with? Either you can give tranexamic acid to inhibit fibrinolysis directly, or change the oxygenator and the circuit to remove the thrombotic burden, restart anticoagulation to treat hypercoagulability, potentially decreasing hyperfibrinolysis, or do none of the above, continue current management with blood product support. What do we do? To answer this question, a 2019 Chest Journal published case series showed that restarting anticoagulation and titrating it to a normalization of LY30 levels resolved secondary hyperfibrinolysis and bleeding. So by treating the upstream hypercoagulability, we aim to reduce the downstream compensatory hyperfibrinolysis. This often leads to paradoxical improvement in bleeding by restarting anticoagulation. And now this might be a game-changing insight. This is the paper that we are going to discuss upon. Let's delve into the aspects of this case series. It describes a series of 6 ECMO patients at Banner University Medical Center who experienced clinical hemorrhage at various points during treatment. 4 were on unfractionated heparin, while 2 had no anticoagulation. Upon applying the novel approach to these patients, upon TEG identification of an elevated LY30 level of more than 7.5%, these patients were either restarted on anticoagulation or switched from heparin to direct thrombin inhibitors, despite active bleeding. And remarkably, there was 100% hemorrhage resolution that was achieved as anticoagulants were titrated to normalize LY30 levels, targeting the underlying secondary hyperfibrinolysis. So after listening to this, let's have a short audience poll. Can we have the poll displayed, please, Habiba? Yeah. So in a patient with both bleeding and evidence of circuit thrombosis, what would you do? Reduce or hold anticoagulation and transfuse blood products, maintain current anticoagulation and focus on local bleeding control, increase anticoagulation based on TEG parameters, or change the circuit and restart with a lower anticoagulation target. Can I please ask the audience to cast their votes? Can we have the results of the poll, please? So basically, what would I do? The takeaway point here is if I am to take an informed decision to increase or restart anticoagulation in an already bleeding patient, which sounds quite risky, the following criteria must be satisfied. There should be a strong evidence of clotting ECLS circuitry, declining oxygenator function or clot burden, and a third most important criterion of a valid viscoelastic assay proof of secondary hyperfibrinolysis pattern in the form of a TEG or ROTEM. Without a TEG analysis, such a decision of increasing anticoagulation in a bleeding patient is usually not possible and is not encouraged. So now to the basic question, why do ECMO patients bleed? To understand bleeding on ECMO, we must recognize the quintuple threat to hemostasis, which begins with thrombocytopenia from platelet consumption, platelet dysfunction due to loss of surface molecules, acquired von Willebrand syndrome from shear stress, heparin unmasking, tissue injury, and waste coagulopathy, leading to hyperfibrinolysis and factor 13 deficiency. These 5 mechanisms create perfect conditions for a bleeding storm. This model explains how ECMO disrupts hemostasis. Blood contact with artificial surfaces trigger factor 12 activation. High shear rates damage von Willebrand factor and activate platelets. Platelet sequester in the circuit. And finally, the body compensates with fibrinolysis, which can often spiral out of control. It's a cascade that starts at the circuit interface. With regards to pressure changes, there are enormous pressure changes within the ECMO circuit, leading to brutal mechanical forces. Blood enters under negative pressure conditions, then transitions to high positive pressure at the pump. The highest shear forces occur at the connector junctions and in the oxygenator fibers. This physical stress directly contributes to something termed as acquired von Willebrand syndrome and platelet dysfunction. Acquired von Willebrand syndrome is a key player in ECMO bleeding. High shear forces unfold von Willebrand factor multimers, making them vulnerable to cleavage by ADAMTS13. And what is the result? Loss of high molecular weight von Willebrand factor multimers that are critical for hemostasis, and this leads to clinical bleeding. The treatment options for acquired von Willebrand syndrome is by supplementation of desmopressin or von Willebrand factor rich concentrates like Q-Met-P. While so many conditions collaborate to cause bleeding, why do we actually need anticoagulation? We need it because without it, the circuit's thrombogenic surfaces trigger clotting, stasis zones in the connectors promote thrombi formation, microthrombi reduce oxygenator efficiency, and systemic emboli can cause stroke or organ infarction. And anticoagulation is our only defense against these risks. ECMO actually activates a vicious cycle between inflammation and coagulation. So coagulation cannot be activated without activating the inflammatory system. Cytokines upregulate tissue factor, complement activation enhances platelet aggregation, the neutrophil extracellular traps provide scaffolding for clots, the damage associated molecular patterns accelerate clotting. This brewing vicious cycle can actually lead to a full-blown DIC. And then there is the blood polymer conflict. Consider the scale of the challenge, almost 2 square meters of foreign material, high shear stresses, high Reynolds number of more than 2,500 at the junction, leading to high turbulence within the circuit and immediate protein deposition within minutes of blood contact with the artificial surfaces of the ECLS circuit. This is why anticoagulation is non-negotiable, and sometimes it is so hard to get it right. But in the recent times, in a lot of scenarios like post-surgical cases, trauma, and pulmonary embolism, we are able to run a high-flow safe ECMO without anticoagulation also. So we've been fighting such a challenge with heparin as our first-line agent since many decades. Why? Because it is cheap, reversible, and familiar, but its disadvantages are significant too. There might be heparin resistance in inflammatory states. Heparin-induced thrombocytopenia is a risk, And the mechanism of action of heparin relies on antithrombin. APTT monitoring is also flawed in critically ill patients. We need to acknowledge these limitations while using heparin. So what is heparin resistance? It is the failure to achieve targets of anticoagulation despite high doses. And how high a dose? Of more than 25 to 35 units per kg per hour. Usually it is because of antithrombin 3 deficiency. And if we suspect heparin resistance, check for antithrombin 3 levels. If the target levels are less than 60 to 80%, we can replace antithrombin 3 by transfusing fresh frozen plasma of 10 to 15 mils per kg or antithrombin 3 concentrate if available. In cases of suspicion of heparin resistance, anti-10A levels would be a better monitoring parameter in comparison to APTT. Next, we come to the management of heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia is quite rare. The incidence is of magnitude 1 to 3%, but it is deadly in ECMO. Mortality approaches 90% if missed. Key steps is to maintain a high degree of suspicion, calculate the 4T score in case of thrombocytopenia. In case of intermediate or highly elevated 4T score, immediately transition from heparin to a direct thrombin inhibitor and order for a platelet factor 4 antibody and functional assays if available. So these are the direct thrombin inhibitors that are available for use, bivalirudin and argatroban. In the recent times, bivalirudin has shown to be a very safe alternative to heparin. And bivalirudin has seemed to prolong the circuit life in multiple conditions, but we need to be aware of there is no antidote available for bivalirudin. Monitoring is via APTT and heparin potting time. There is lesser ECMO experience with heparin, and the half-life is 25 minutes. Let's compare different populations. Anticoagulation is definitely not one size fits all. Pediatric patients need higher heparin doses and more frequent monitoring. COVID-19 patients are hypercoagulable, requiring higher targets and antiplatelet therapy. Population-specific adjustments are non-negotiable for safety. With regards to pediatric ECMO, children are not small adults. Neonates have developmental hemostasis, higher platelet activation, lower antithrombin levels, and reduced vitamin K factors. This demands age-stratified protocols, antithrombin supplementation, and lower thresholds for circuit changes. With regards to COVID-19 ECMO patients, sometimes they might present with extreme hypercoagulability. We have seen elevated D-dimer, fibrinogen, factor 8, and von Willebrand factor levels. So the pragmatic approach would be to approach with a higher anticoagulation target of 60 to 80 seconds of APTT, use TEG monitoring whenever available, and a low threshold for circuit changes. Sometimes antiplatelet therapy might also be added. So this is a practical algorithm for anticoagulation selection decision tree, where you can start with heparin unless contraindicated. For suspicion of heparin-induced thrombocytopenia, immediately switch to bivalirudin or argatroban. And for heparin resistance, try supplementing antithrombin 3 by transfusing FFPs or antithrombin concentrates. And in case of refractory heparin resistance, you can also transition to direct thrombin inhibitors. We have a multitude of anticoagulation monitoring parameters that are available, and we can see that all these parameters have their own advantages and disadvantages. No single test is perfect. APTT is cheap but unreliable in inflammation. Anti-10A measures heparin directly but is not real-time. TEG or ROTEM assesses the whole blood function but requires expertise and repeated calibration. ACT is rapid but insensitive. And so what is the solution? We have to try to use the best of each world, that is multimodal monitoring. Let's now discuss some evidence with regards to TEG. So this is a single center randomized control trial performed by Panigada et al. And they compared a TEG-driven approach versus an APTT-driven approach for heparin administration in VV ECMO. They randomized 42 patients over 7 days, and they studied outcomes including bleeding, thrombosis, heparin dosing, and transfusions. And the results were quite striking. In the TEG group, anticoagulation was titrated to an R time of 16 to 24 minutes, and in the APTT group, the target APTT was around 1.5 to 2 times the baseline. And here we can see with regards to heparin dosing, there was significant lower heparin doses in the TEG group when compared to the APTT group. There was 30% reduction in the heparin requirement to achieve the anticoagulation targets. And the TEG reduced bleeding by 32%, thrombosis was reduced by 18%, and blood product use was reduced by 57%, all of these with 30% lower doses of heparin. Why this is possible with TEG? Because TEG avoids over anticoagulation and pinpoints real needs. Let's see about a quick TEG primer. This picture shows the R time, where R time is the time taken from the activation to initial clot formation, and then comes the K time, where it is the time from R to 20 mm of clot strength, and then is the alpha angle. That is, it gives us information about the rate of clot formation, and then comes the maximal amplitude, which gives us the greatest clot strength, and then is the lysis at 30 minutes. That is the percent decrease from maximal amplitude. So basically, TEG is a real-time movie of coagulation, unlike the snapshots that we get from traditional parameters like INR or APTT. TEG aligns with the physiology. TEG mirrors the cell-based coagulation model. It can give us information about the initiation of the clot formation by R time. It can give us information about the amplification by means of the maximal amplitude, and it can also give us information about the fibrinolysis by LY30. TEG can help us recognize 3 patterns, either hypocoagulable state, hypercoagulable state, or a fibrinolysis state, or multiple combinations and permutations of these conditions. TEG personalizes anticoagulation. Traditional tests are static and plasma based, while TEG is a whole blood and dynamic assay. It detects fibrinolysis in real time, unlike the delayed D-dimer detection and non-specific D-dimer detection. TEG can help us transform transfusion decisions. So let's see how TEG in ECMO helps us to target hemostasis and reduce transfusions. We'll take an example where platelets are low, but maximal amplitude is normal. So what does this mean? It means that the reduced number of platelets is still functionally adequate in terms of clot strength. So we can skip the platelet transfusion. And if INR is high, but R time is normal, then we can skip an FFP transfusion. Basically, we can target replacement to functional deficits only and not target correcting just arbitrary numbers. So reduced transfusions, basically, they will give us lower incidence of TRALI and transfusion-associated circulatory overloads and a prolonged ECLS circuit life. So here, let's take a scenario where there is low maximal amplitude but with normal fibrinogen. We can see that there is an intelligent combination of TEG as well as the laboratory assay, which is fibrinogen. So here, since there is low maximal amplitude, but the fibrinogen level is normal, we have to consider platelet transfusion. And in a second scenario, there is low maximal amplitude as well as low alpha angle. So in such a scenario, we have to consider cryoprecipitate or fibrinogen concentrate transfusion. Here's a comparison between ELSO's lab-based thresholds or transfusion triggers for transfusion targets versus a TEG-based algorithm. So here we can transfuse only if TEG has a low maximal amplitude, but ELSO suggests transfusion if the platelet counts are less than 50,000. And in case of INR, if INR is high, we have to transfuse according to ELSO. But with regards to TEG, we can only transfuse if we have a low maximal amplitude. So TEG approach reduces transfusion without increasing the risk. And after listening to this about TEG, if you are ready to implement TEG, then this is the following checklist. Get the baseline TEG pre-ECMO, train your team on interpretation, define interventional thresholds for TEG parameters, integrate with other tests, and audit the outcomes. The data for TEG is compelling, at least 50% fewer transfusions, lower thrombosis rates, and optimized heparin dosing. Studies from Panigada et al., Chandel et al., and Nakashima all support this. And let's crystallize the key takeaways regarding TEG. TEG provides real-time functional assessment. It reduces unnecessary transfusions and complications. It enables target therapy for fibrinolysis and thrombosis, proven benefits in ECMO patients, and this might well be the future of anticoagulation management in ECMO. So these are the common problems that we might encounter in anticoagulation management: bleeding risks like GI bleed or intracranial hemorrhage or hemothoracis, thrombotic complications of the circuit or oxygenator, monitoring discordance of different parameters, drug device interactions, and the protocol variability between institutions. So what do we do if there is a discrepancy between multiple parameters? In case the ACT and the APTT don't agree, use a third parameter like anti-10A. If the APTT and anti-10A don't agree with each other, use a third parameter like TEG monitoring. Use multimodal monitoring effectively. Consult hematology whenever possible. Try to use the oxygenator as your clotting barometer. Watch for higher transmembrane pressures, falling PaO2, rising prehemoglobin, or visible clots. Trend these parameters every day. Use a flashlight test in every shift to examine the oxygenator for clots and thrombi. Consider using combined bleeding and thrombosis management algorithms. Start with patient assessment, baseline tests. In complex cases, please use TEG or ROTEM and anti-10A levels. Assess the circuit function. And then please don't forget the calcium, temperature, and the pH. These are basic things that we have to correct. And if these are not corrected, then whatever modifications we do to the anticoagulation protocol, they might not work. And finally, building your institutional protocol. How to build an institutional anticoagulation protocol. Assess your resources in your hospital, like lab tests, lab turnaround time. Assemble a multidisciplinary team involving intensivists, surgeons, interventional radiologists, hematologists, perfusionists, and nursing. Define clear thresholds for transfusions and waiting. Define clear escalation pathways and tailor it to your institution, and please do regular audits. So this might be a near ideal framework for a protocol. Definitely multimodal monitoring, never rely on one test. Get in-depth baseline pre-ECMO assessment. Institutional customization is key, and multidisciplinary input. So my take-home message would be patient-centered decision-making instead of correcting numbers. And if we follow the above insights, the future seems quite bright and promising. There is a lot of research going on with biomimetic and advanced surface coatings. Professor 𝐀𝐧𝐭𝐢𝐜𝐶 would enlighten us regarding how nitric oxide in the ECLS circuit can help prolong circuit life. And thank you for patient listening. I'm happy to take questions if there are any. Thank you.
Thank you, Dr. Arvind. It was a very nice talk. It's covered all the groundwork for anticoagulation and circuit and coagulation. Let's see if we have any questions from Q&A. At the moment, there is no questions there. And in the meantime, I can ask you one of the questions before anybody else from the audience. I think, what is your anticoagulation strategy when covering patients post-bypass and converting to an ECMO circuit? Because obviously on cardiopulmonary bypass, patients will be fully anticoagulated. And when you convert it to the ECMO circuit, how would you treat it? Would you just convert it, give the protamine first? What is your strategy? How do you do it?
We would give the protamine first, reverse the full anticoagulation, and then document baseline ACT and APTT, get an in-depth baseline coagulation profile after reversing the heparin with protamine, and then restart anticoagulation for ECMO after a couple of hours, maybe. Yeah.
Okay. So you will not convert it straight away with the same heparin. Let's say the ACT is 480 and you converted it directly to the ECMO. You won't do that and then give protamine when patient is on ECMO.
No, no.
So you will give that protamine first, like you come off pump, and then obviously take all the cannulas out. What time you place the cannulas in? Obviously, you will place the ECMO cannulas in at the same time. It will happen all simultaneously, right?
Yeah.
All right.
Yeah. OT. Yeah.
Anyone else has any questions from the panel, if somebody wants to ask?
Maybe I'll ask a quick question. So if you're in a center where you don't have anti-10A levels, you have a PTT, you have an ACT machine, which one would be your preference, PTT versus ACT, in the absence of anti-10A levels?
In the initial 2 days, we would use both ACT and APTT, use ACT a lot more frequently, like every second hourly, and APTT sixth hourly. And once we get a steady state where ACT and APTT are going to trend alongside, then we would shift it to APTT sixth hourly. So that is how we practice it.
So if you have disagreement in the initial period, you would go with the ACT, and then later on you would go with PTT. Is that correct?
Yes.
Perfect. Thank you.
Okay, we have time for one more question. Let me see in the audience. So if you look at the second question, what do you think about following APTT ratio, sir, and titrating heparin according to APTT ratio? That's the question.
Yeah. In some patients, we might see that the baseline APTT is elevated. Like there are conditions like there are conditions where isolated APTT elevation is there, some because of the presence of some inhibitors or something. In such cases, we should not target an absolute APTT number, but 1.5 to 2 times the baseline would be a better value to target. And we can always trend. One single value should not be targeted. A trend gives us more information than a single number.
Okay, thank you. I think just to keep the time tidy, thank you very much, Dr. Arvind. I will hand over to Dr. Salman Abdulaziz now, who will take over from here now to introduce the next guest speaker. Thank you.
Thank you, Dr. Salman and Dr. Arvind, for your nice discussion for the first topic. Navigating further through the academic program of tonight, I would like to present or introduce Dr. Ahmed Al-Ghamdi. He's my colleague in King Fahd Medical City in Riyadh. He's a consultant of cardiovascular critical care and cardiac imaging. Dr. Ahmed is a young generation consultant who had finished his clinical fellowship in Western University of Canada. For tonight, he is going to present about more highlights on the cardiovascular critical care fellowship program that is introduced by the World Institute of Critical Care and Emergency Medicine. Dr. Ahmed, it's yours now.
Thank you, Dr. Salman, for this introduction, and thank you, Dr. Arvind, for your talk. Okay, so it's my pleasure to introduce our Cardiac Critical Care Fellowship Program, which is designed to equip a fellow to advance skill and knowledge to deliver exceptional care in this highly specialized field. So this fellowship is structured to be a one-year program divided in 3 comprehensive modules. Each module will last for 16 weeks, including the final exam. All modules combine of audio and video lectures, giving our fellow the flexibility to learn in on pace while maintaining the structure milestone. Each module follow a clear outline, which will engage the fellow to dictated lectures that encourage reflect practice, always aligned with up-to-date international guidelines. There will be an MCQs will provided with detailed answer and explanation to enforce the learning points, case discussions to enable the fellow to apply the knowledge in real-life scenarios, and critical appraisal session to train the fellow to analyze and to interpret reviewed scientific publication to enhance their research critical thinking. Our program, led by Dr. Ashwag, which is our program director, and Dr. Ahmed Hijazi, our academic director, and supported by international academic board member comprising expert faculty and guest speakers. Our goal for this fellowship program is to close the gap created by limited resources in this field, to enhance the knowledge from multiple perspectives, medical and scientific, to focus on managing a special complex patient population which have been achieved better clinical outcome if they managed appropriately, to develop an advanced competency and expertise in managing MCS. Material instruction, our e-learning platform is interactive, include critical thinking exercise, MCQs, group discussion, and complex case analysis. All scientific material and instruction are accessible through the platform. With the new content will be also released every Monday at 8 a.m. by Greenwich time zone. Fellow will have flexibility to navigate the material and complete assignment throughout the week, with all tasks due by weekend. And to ensure quality and accountability, all activities and assignments are monitored. We perform a qualitative and quantitative assessment to evaluate engagement and overall assessment of progression. So after successful completion of the program, the fellow will receive an American Accreditation Association certificate along with CME credits. He will gain knowledge and troubleshooting skills in mechanical circuitry support, and he will master comprehensive management of cardiac critical care patients. So those are modules. Module 1 will be a foundation of cardiac critical care, which include physiology, pathophysiology, anatomy, medication, hemodynamic monitoring. Module 2, it will be a perioperative cardiac critical care, which is be an intraoperative, postoperative management and complication. Module 3 will include the mechanical circuitry support. Starting date will be in 1st of September, and you are welcome to ask any question. Feel free to reach us for further information through the website, or you can direct email Dr. Ashwag in her email. Thank you for your time and your interest, and hope to see you there, inshallah. Thank you, Dr. Salman, and the mic is yours.
Thank you, Dr. Ahmed. Very short and sweet, focused orientation about the program. We had a question from the audience about the CME accreditation. Would it, oriented to, or just, accredited by the Saudi Commission of Health Specialties?
Okay, so CME hours, it will be accredited by the American Association. It's not Saudi Council or Commission.
Excellent.
May I answer this question? So for the free webinar, it will be no CME hours. For the fellowship, it will be American accredited. However, that certificate and that CME hour can be applied to the Saudi commission, and it usually with 50 or 100 riyal, and it will be awarded CME hours. So for the total fellowship, it will be like 90 hours.
Okay, thank you, Dr. Ashwag, for the elaboration. So we'll proceed now to the third lecture for tonight. I'm going to introduce Professor Gilles Peak. He's a professor of congenital heart disorders, cardiac surgery, and also he is a cardiac intensivist and anesthetic. His background, he was graduated from the Royal College of Anesthesia from United Kingdom, and he had a great move to United States, as he's working now as and a senior expert of extracorporeal life support, mobile ECMO program, pediatric, including pediatric and adult patients, in addition to his practice of cardiac surgery. So this is a recording, and I hope that you will enjoy it till the end. You can start now.
Hello, my name's Gilles Peak. I'm an ECMologist and congenital heart surgeon from the University of Florida in Gainesville. Today I'm going to talk to you about breaking the clot. Can S-node protect the ECMO circuit? In this talk we'll be talking about the link between coagulation and inflammation, and how nitric oxide in the sweep gas can reduce both inflammation and clotting. I've no financial disclosures, but I'd like to reiterate the importance of the team in caring for ECMO patients, and the central position of Esperanza, the first neonatal ECMO patient, with her doctor, Dr. Bartlett, at the centre of this slide is no coincidence. Ever since the early days of extracorporeal life support, when Ted Colombo invented the solid silicon spiral coil oxygenator, blood surface interactions have been crucial to developing safe extracorporeal life support. Here's Ted and Warren Zapol in the lab in Bethesda. Of course, Warren Zapol went on to develop the use of inhaled nitric oxide. This is the first successful ECMO patient, treated in 1971 by J. Donald Hill, and as you may remember, this is a patient who suffered multiple trauma and a ruptured thoracic aorta and developed ARDS after successful surgery. So right from the outset, management of anticoagulation, trauma and bleeding was central to the success of the first ECMO patient. The shift from solid silicon to polymethylpentene solid fibers meant that surfaces could be coated, because it's very difficult to coat silicon, and also reduce the total surface area. You can see here on the right the twin silicon oxygenators we used to have to run for adults, and you can see the much more compact modern PMP membrane in the middle. The original anticoagulant used during ECMO was unfractionated heparin. In the modern era, people are beginning to use low molecular weight heparin and increasingly direct thrombin inhibitors, mainly bivalirudin. And I believe that direct thrombin inhibitors will replace heparin as time goes on. Even despite these anticoagulants, you can see significant clot formation, as shown here on this clot extracted from a bladder box from a roller pump circuit. I've been interested in blood surface interactions right from the early days of my ECMO career, and indeed my doctoral thesis is concerning this matter. Of course, the platelet is very central both to coagulation and also to inflammation, as we will see as the talk goes on. Now, we're all used to thinking about nitric oxide in the ventilator gas and its effect on modulating pulmonary vascular resistance, but we probably don't think of the role in biology of nitric oxide at the vascular endothelium, and of course its effect on reducing platelet activation. It turns out, of course, that nitric oxide is extremely effective in reducing platelet activation, and it's extremely easy to put nitric oxide in the sweep gas. This was not my idea. Many people have thought of this and tried this previously, but I've been particularly keen on using this clinically for the last 4 or 5 years. These are some papers from our group, one discussing the biological activity of nitric oxide, and another one describing our early experience of using this in children. This retrospective study doesn't really demonstrate efficacy, but it does at least show safety and describes the experience of our first 19 children that we gave ESNO to. A more in-depth review of this is undertaken by Adrian Matke at the University of Queensland, and I'm very grateful to Adrian for sharing his slides with me. This was the NECTAR trial, which is a randomized study, but as you'll see, didn't really demonstrate efficacy, but does, I think, go some way towards increasing the idea that this is a safe intervention. And if you want to get in touch directly with Adrian, here's his email address here and the rest of the study team. So, nitric oxide in the sweep gas has been shown to reduce platelet activation in experimental cardiopulmonary bypass. This effect is confirmed in clinical practice, but the exact dose that's best, or indeed the best route of administration, is yet to be confirmed, and you'll notice this paper is from 1998. More recently, this has been investigated, and the physiologic effect, rather than the effect on platelet numbers and inflammation, has been looked at, and very little effect in terms of reducing the physiologic impact of the heart operation in the nitric randomized clinical trial during bypass, of course. So here's an interesting study which raises another question. Although the combined use of heparin and nitric oxide did not show any effect on coagulation and inflammation in both ECMO and cardiopulmonary bypass done in the laboratory, it raises the question of whether the effect is the same when we use a direct thrombin inhibitor, and I believe that this is an important distinction. Now, many groups are looking at this in clinical practice. This is Kevin Pan's study, which was published in the SIO last year, using nitric in the sweep in ECMO on children, and didn't show any difference in survival, but did show fewer circuit changes, lower blood product use, and a lower risk of neuroinjury in children that had been on bypass. So moving on to the NECTAR study, this is going to be published very soon, and basically it's looking at using nitric in the ECMO system at a dose of 20 parts per million. It's a randomized controlled trial. It's not blinded, obviously, because it's pretty obvious whether nitric is running in the sweep or not, and it's a fairly small single-center study. Their ECMO setup is Rotaflow and Quadrox for small patients and CardioHealth for larger patients, and they're using heparin as their anticoagulant. And the standard dose of ESNO is 20 parts per million. Now, the bias flow in the ECMO, in the nitric system is important because most systems designed to deliver inhaled nitric oxide have a minimum flow of around 2 litres a minute, although the more recent devices, that's reduced to 500 mils. So the NECTAR study was done using this Inotherapeutics or Mallinckrodt device, Sockinox, which is available in Australia, not in the United States. And here's the setup in the sweep gas, as you can see. And these are the flow and sampling rates. And these are going to vary depending on which nitric system you are going to use. And you're just going to have to work out what the flow rates are for your particular devices. Of course, if the bias flow is too great and you're beginning to blow off too much CO2, you can solve this by adding CO2 to your sweep gas. Now, bear in mind that the study design is not powered to detect significant differences, and this is really, I think we should see this as a safety study more than anything else. This is the consort diagram of the recruitment, and the compliance with the intervention, which is pretty high. And this is the patients that they treated. And you can see here that it's a mixed bag of patients. The overall numbers are quite small. And there's a mix of patients with heart disease, respiratory disease, and so I think this also has an impact on how much you can draw from this study, not minimising the importance of it. And these are the reasons for ECMO support, baseline characteristics, the type of support. You can see predominantly VA ECMO, but with a significant number of vena-venous ECMO patients. Anticoagulation with heparin based on a target anti-10A level, so not applicable to when we're using bivalirudin, which I think is much, much better than heparin in my experience. So no real differences between the groups, and again, the study not powered to detect any, no real incidence of hemoglobinemia. And survival also not really different between the groups. And of course, overall, such low blood product usage that in both groups that you can't really derive anything from this, which is entirely consistent with modern ECMO practice with polymethylpentene oxygenators. So in summary, I think what this study shows is that it's feasible, and that really the patient population in this study is not sufficiently large or homogeneous to draw any firm conclusions. It definitely shows that in this group of patients, ESNO is safe and doesn't really tell us anything about clinical efficacy. Now, this is Adrian's interpretation of some of the issues, and particularly I agree with this thing about us not knowing what the correct dose is. Bob Bartlett and I spoke about this last week, and he's using 100 parts per million in the laboratory as a sole anticoagulant and finding it very effective. So I think we don't yet know what the correct dose is. So looking at other things that we can get from this, I think we do need to look at the biology of this, particularly cytokines, and also the way that the platelets are activated in terms of coagulation as well. Also from the University of Michigan, 𝐀𝐧𝐭𝐢𝐜 as part of the artificial placenta group, has been using 80 parts per million as an anticoagulant, sole anticoagulant in this artificial placenta model. So that's all the science we have so far. I think we can say it doesn't do any harm. I personally believe it does a lot of good, and I'm going to tell you a campfire. So I hope you're ready for a campfire story.
So we have a technical problem. So IT, can you fix it?
Meanwhile, I have a question. Did anyone of you use the nitric oxide before? Any experience in our panelists?
I'm sorry, could you please repeat the question, please?
So did any one of us use nitric oxide before in high risk bleeding patient? Because honestly, I just read about it. I never use it and I never see it in any one of my patient. Neither I don't know any of my colleague who did this before, but I can see it in the WhatsApp group of the ECMO.
Yeah, same here. But one of my colleagues has started using it in India, and they found good results, no bleeding complications, and a good circuit life was there with minimal anticoagulation.
Okay, thank you. I think we are ready to continue the presentation.
This is a story about a patient called Aubrey who came to our hospital last year. She was 4 months old when she developed RSV pneumonia with multibacterial necrotizing lung changes. She went to her outside hospital local to where she lived on the first day of illness, intubated by day 8, and then deteriorated with cardiogenic shock and respiratory failure. This hospital did not have ECMO, so our ECMO team went out and their surgeons cannulated, and then she was transferred immediately back to UF on VA ECMO. And this is a CT we did not long after arrival, and you can see the blobs of Staph aureus of MRSA in both lungs. And here she is on VA ECMO, and you can see those on the plain film. By day 14, her heart had recovered, and I converted her to VV double lumen. And her disease progressed to kind of bullous disease via a phase of complete whiteout and solidity of both lungs. And nothing much happened. Her lungs did not recover, and she grew on ECMO. And so we upsized her cannulas to VV multi-site to provide her with more support. And we did a tracheostomy, and that allowed us to wean her off rest ventilation. But these massive air spaces in both lungs persisted. Eventually, her lung parenchyma recovered, and with the breathing spontaneously and mobilization, that allowed us to decannulate her on day 234 of ECMO, which is her first.
Go, Avi, go! Go, Avi, go!
So mobilizing her on ECMO was very, very important.
I can't see myself. I can't see myself.
And this is her trialing off. She had her birthday party the day before we took her off, and that's her friend Marco, who was bridging to a double lung transplant. They're both long-term survivors. So during the trial off, the housing on the membrane cracked and it started to drip blood onto the floor. So I cut it out and we continued the trial off just with a loop of tubing. But this particular oxygenator was the third ECMO circuit that she had, and it had been running for a total of 5 months. So this is with bivalirudin and 20 parts of nitric in the sweep gas. So taking the membrane off, we immediately flushed it out, and I sent it to the AREVA group in San Antonio, where Andrew Baczynski and his team have an ongoing research protocol where they look at oxygenators. And this is one of his test animal model oxygenators using heparinized blood. And this is what a PMP membrane looks like. Now this is Aubrey's oxygenator after it's been cut and spread out. And you can see it's completely pristine. So there's no clot on there at all. And I think that's quite important after 5 months and fairly impressive. So by day 42 post-ECMO, we got her down to room air, and then by day 51, we removed her tracheostomy, and eventually on day 289, she went home after a total of 301 days in hospital. And this is her CT and chest X-ray just before we took the tracheostomy out. What do you think? What do you think? Before discharge. So, I think that this shows that SNO prolongs membrane life. I think the way that her lungs recovered shows me that I think it does have an anti-inflammatory response that's important in terms of the patient recovering. And I think both of those things are important effects which contribute to survival. Clearly, we don't know what the right dose is yet. Clearly, we don't know if all patients benefit from it or some patients, and we've got to look at this in more detail.
Look at that big girl! Look at that big girl!
So we're collaborating with a number of different centres to look at this, and I'm mentoring Zasha Vasquez-Colon, who is one of our attendings, who has an active interest in this, and this is one of her previous studies looking at blood surface interaction with tethered liquid fluorocarbon. So if you're interested in this, please email me or Zasha, and we will try and include you in our ongoing studies. Thank you very much.
Thank you very much, Professor Gillis, for your presentation. So regarding the questions of this particular topic, I would suggest that all join the WhatsApp group specific for this fellowship program. And Professor Gillis is going to be there to answer all the questions immediately. Now, just, looking to the question and answers list, there are many questions related to the first presentation and the second presentation. And I'll just leave Dr. Salman, but to, direct the questions to Dr. Aravind and also Dr. Ahmed as well. Dr. Salman.
I think you're muted.
Sorry about that. I think Dr. Aravind has already answered many of them. I think I can see in that text window that is most of them have been answered. Let me just go through if there's anything. I think one of the questions he already answered. I think there was one of the person who was asking a question about conversion from CPB to ECMO, was how it was done, and I think he's answered it. If the patient is quite sick and you don't have time to convert it from giving the protamine first and then decannulation and then converting into ECMO, sometimes people just convert straight away. So we have an experience in the past that and we also published a recent paper in ATS regarding the same dilemma. I think it's a big question where people actually find that, and there has to be some sort of consensus or policy needs to be developed. So it has been accepted and published. So we can always share that link into the WhatsApp group, which will be shared later, I think. What we did in a couple of patients is actually we have converted straight away onto the ECMO because patient was sick, because it doesn't give you, it's like simultaneously, you actually put, and then you give protamine on ECMO. So the ECMO, once you do the baseline ACT, that's sort of how we did it. If the ACT was, let's say you repeat from heparin to protamine, it will be 1 to 1.5, or some people give 1-to-1 ratio when you reverse the protamine heparin. So I think what we did was we given in very slow interval of time. Let's say the baseline ACT at the time was 400 when we converted to the ECMO, and then it was given like the total dose was about 300. I think we given about 50% to start with. So we gave like 5 mils of the protamine and then check the ACTs and then gradually. So it didn't affect the circuit at all. So if patient is sicker, you can actually do it this way, and it's actually quite safer, but you don't go in quickly, the full shot. It's always like it takes about a quarter of that. It's still the right dose has to be identified. So that's why it's a dilemma if you actually are converting, not converting, what time it needs to be done. So I think it's a big question. which still needs to be answered. So that's that part. I think any other questions? I think most of them have already been answered, to be honest, by Dr. Arvind from the first part. And if anything is left, I think in the group can be asked later, I think. And if everybody's happy, we could actually conclude the session.
I think you can conclude already.
So before we conclude, Dr. Salman, this is for the IT. Can you share the WhatsApp group number and also the name of the WhatsApp group so all can join after this presentation? Dr. Salman, it's yours now.
So the WhatsApp group has been shared in the chat box. You can join it. Feel free to join. And I would like to thank all the panelists, all the guest speakers, and the audience, whoever has attended this session. And we hopefully will be sharing you next sessions and updates in the WhatsApp group and also on the social media. Thank you for everyone for joining us. Thank you.
Thank you. Like,
شكرا يا حبيبة، يعطيكم العافية.